Welcome to the channel. In this scenario, we are working on a Mr. Claude Johnson, who is a 74-year-old male that comes into the emergency department complaining of weakness in the left arm and leg. So let's get started. The first thing we should do is always interview our patient while they are awake and find out what happened. Our patient is telling us that he woke up this morning and couldn't move his left arm and leg about 7 hours ago. He informs us that he is not allergic to anything and that he takes blood pressure and statin medications, but he is not sure what they are called. Additionally, he is not experiencing any pain at this time. So now we are going to transition into getting our baseline vital signs consisting of a pulse oximeter, a 3-lead ECG, blood pressure, and temperature. Here we can see that we have a blood pressure of 131/86 with an SpO2 percentage of 96 on room air, a temperature of 37.1 degrees Celsius, and a heart rate of 94 with atrial fibrillation on the ECG monitor. So now we will get an IV started and start a bolus of 1 liter of saline and start a slow drip of 75 milliliters an hour of saline. We will confirm our 3-lead AFib interpretation with a 12-lead EKG, which does confirm our initial diagnosis. It is worth noting that no arrhythmias are specific to strokes, but that AFib drastically increases the chances of an embolytic stroke. This type of stroke accounts for approximately 87% of all strokes. We will get a glucose and a venous blood sample started while we continue to assess this patient. This concludes step 3, the immediate general assessment and stabilization of the adult suspected stroke algorithm. That can be found on page 134 of the ACLS Provider Handbook and is now on your screen. You can see here that the recommendation is that this portion should not take longer than 10 minutes. In our case, we have done this in approximately a minute and a half. We will now go to step 4, the immediate neurological assessment by the stroke team or designee. We will perform a NIH stroke scale and a CPSS stroke scale and record our findings for later comparison. This is a very important part of our assessment and is the foundation for subsequent treatment. Now that this is done, we will transfer the patient to CAT scan or CT to get a non-contrast study of the head so that we can differentiate between a hemorrhagic or embolytic stroke. Prior to leaving for CT, it was noted that this patient had a NIH score of 8 and has facial drooping on the left side with markedly reduced strength on the left arm. There were no issues with sensation, and there was correct use of words without slurring. Now that our patient is back, we will repeat a NIH and CPSS stroke scale and compare our results to the prior findings. During the middle of our assessment, the CT scan results came back, and we are informed that there is no bleeding occurring. This patient is suffering from an embolytic stroke. Initially, this patient told us that he had gone about 7 hours before he came in to be assessed, and as such, he has exceeded our 3-hour window to give fibrinolytic therapy. Since he is not a candidate, we will give 300 milligrams of aspirin rectally to prevent potential aspiration due to acute embolytic stroke. You can see how the ACLS algorithm for acute stroke treatment is dictated here for this particular patient on the screen now. The results from our second NIH and CPSS stroke scales were the same as the first one, and we can conclude that this patient is not getting worse at this time. We will get a quick chest x-ray and begin transfer of the patient to a stroke unit. While a full head-to-toe assessment is warranted, these are the critical steps to manage the acute issue for this patient suffering from an embolytic stroke. Here you can review our assessment and the course of treatment with timestamps. Please note that for this scenario that the American Heart Association did not flag us for inappropriate practice. You may want to consider pausing the video now to review these if you are interested. I hope you learned from this video, and we'll see you next time. Stay safe.